This mini lecture is going to look at Chalazion and Hordeolums, and these are two conditions that you see very frequently in primary care as well as in an urgent care or a walk-in center. So the chalazion is a lump in the upper or lower eyelid which is caused by an inflammation of the gland of the lid. And it starts out as a very small red tender swollen area of the eyelid, and in a few days it does change to a painless slow-growing lump, probably around the size of a pea. The eyelid glands are called the meibomian glands, and these glands are known also to have about 30 to 40 of each in the upper and lower lids. They produce a very thick liquid secretion, and it is discharged into the tear film of the eye. This liquid is a mixture of oil and mucus called sebum, and the liquid then maintains the lubrication of the eye. The tiny openings of each of these oil or sebaceous glands are just behind the eyelashes at the lid margins, or both the upper and the lower lids. They're painless lesions not involving the eyelashes, so you will not usually see any loss of eyelashes. And it could be soft and fluid-filled or even firmer. Some of the causes of a chalazion, well, there's a narrow opening through which a meibomian gland secretes material that can become clogged from the narrowing of the opening or hardening of the sebaceous liquid near that opening. So the gland then, what happens is, will back up the material and it does secrete, and it obstructs the gland, causing it to swell. This also then will lead to the walls of the gland becoming thick and oil leaking into the lid itself, and it causes inflammation both within the gland and the eyelid. And when this does occur, this is when the chalazion is occurring. Some of the risk factors include not only prior history of a chalazion, but also acne rosacea, chronic blepharitis, seborrhea, tuberculosis, viral infection. Rarely, but it's possible to see a skin cancer. And then some very oily skin, as well as mite species, have always been seen too, and that usually is in the lash follicles itself. Some of the signs and symptoms of someone who does have a chalazion: it is a firm, non-tender nodule. Occasionally, you will see that the eyelid is diffusely swollen. The eyelid can be massively swollen, shutting the eye completely. And usually after 1 to 2 days, a chalazion localizes to the body of the eyelid. So typically a small, non-tender nodule or lump develops at that eyelid border. It usually does drain through the inner surface of the eyelid or is absorbed spontaneously over about 2 to 6 weeks, and it rarely persists longer than that. So depending on its size and location, it may indent the cornea and cause blurred vision. There can also be sensitivity to light as well as pain, but usually it is a non-painful situation. And these are pictures of two chalazions. You can see that there's one that's internal as well as some that are external, and you can see the difference, how some of the pustules are starting to form. Some of them just look like a big ball, and there's no evidence of any pustules there. So when we're looking at our history for these patients, we want to look at the onset and duration of symptoms and ask about their visual acuity, if their visual acuity has been affected. So that could be something that could be concerning. If the lump itself is large enough to distort the ocular surface and causes blurring of vision, that could be a concern, but that rarely does occur. Usually the vision will return to normal once that chalazion gets smaller or it's removed, and the pressure on of the chalazion does not cause any type of glaucoma or anything like that, and it is not contagious. When you're looking at the review of systems, you want to ask about family history. Have they had a history of any other eye problems at all that they want to tell you about? Have they had a history in the past of a chalazion? And what do they, what else have they had in relation to their eyes, or any other medical history? On physical exam, your priority is to assess visual acuity, and if they're having difficulty You can put up your two fingers if they can't see the Snellen chart and let them tell you how many fingers they have up. There also is just basically the chalazion is diagnosed by the medical history and the finding of that firm, non-painful lump in one of the eyelids. So the diagnosis can really be made by inspection with a pen light or even palpation, feeling the lump. So you want to be palpating the eyelid, averting the eyelid, looking at the inner surface, as well as inspecting the sclera and the conjunctiva. So this is really a self-limiting condition. Most chalazions are treated with warm compresses to the eyelid to increase the circulation of blood to the inflamed area, and that also does help to promote healing. In addition, you may prescribe an antibiotic drop or ointment to be used immediately after the compresses, but usually that is not necessary to do. This You also may need to send them to an ophthalmologist if they need to have incision and curettage, if there is no resolution, if they have any headache, fever, visual changes that are really, persistent, as well as eye pain, drainage. Both eyes are swollen, and they may need to remove this chalazion. And the removal, it doesn't really alter the normal function of the lid nor decrease the amount of tears. It just really only removes the gland. Which you have many more in that eyelid, so it just removes one gland out of those 30 or 40. It doesn't really cause any problems for long term at all. The use of warm compresses when you do apply them to the lid should probably be done about 4 about 4 to 5 days, 3 times a day, maybe for about 5 or 10 minutes before they go to bed, and that does help the meibomian glands from further clogging during the night. In some people with seborrhea of the lids and current chalazions, then you may need to do careful cleansing of the lid just to help for prevention. So when we look at differential diagnosis, we're looking at hordeolums, we're looking at blepharitis, we're looking at sebaceous cell carcinoma, which is very rare, and an embedding foreign body. So those are just some of the things that we need to think about when we are looking at someone who does have a chalazion. For medical management, we talked about this with pharmacological intervention really not necessary. Antibiotics are not needed because this is a granulomatous condition, and refer them to an ophthalmologist if there is no resolution within 6 weeks, and have them come back in 2 to 4 weeks to see you, just to see how they're doing and make sure that they're not having any problems. Now we move on to a hordeolum, and the hordeolum is really a stye. It's an acute localized swelling of the eyelid that may be external or internal, and it usually is a pyogenic infection or abscess, so it's typically a staphylococcus. Most hordeolia are external and result from obstruction and infection of an eyelash follicle and adjacent glands of the zeiss, which are the external, or the meibomian glands, which are the internal. It is more common in adults than it is in children and adolescents, and sometimes the patient can get a cellulitis from this. Some of the causes of a hordeolum is the thickening of the gland, so the secretions from the gland. So what happens is that the zeiss gland or the meibomian gland orifices really are not able to secrete. So they get stasis of those secretions, and then that's when they end up getting the secondary infection of staph. And if somebody does have multiple recurrent hordeolia, you have to start thinking about immunoglobulin M, because that is one thing that could be a cause of hordeolums if they're getting them over and over and over again. Some of the risk factors, well, individuals with the following have the risk factors, and it's very similar to chalazion, where they have the chronic blepharitis, the meibomian gland dysfunction, as well as rosacea. But with the hordeolum, it's a little bit different. The chalazion has been found to have large cholesterol content. So the elevated lipid levels can cause blockage to those oil glands of the lids, and can predispose the patients to both a chalasia as well as a hordeolum. So thinking about someone who has high cholesterol levels, and if they're coming back over and over, that might be one thing to check if you have not already checked that they have had cholesterols done. Some of the signs and symptoms, well, after about 1 to 2 days, an external hordeolum localizes to the eyelid margin, and there may be tearing and light sensitivity as well as a foreign body sensation. Typically, there's a small yellowish pustule which develops at the base of the eyelash, surrounded by some redness and swelling of the lid, as well as some induration and diffuse edema, as I said. But within 2 to 4 days, that lesion does rupture, and there will be pus that does come out of it, and that helps the pain to be relieved as well as resolving of the lesion. So if it is a posterior hordeolum, it will be on the conjunctival side of the lid, and if it's anterior, it will be on the lid margin, and it's usually from an eyelash follicle or a tear gland. And this is a picture of internal and external hordeolum, and the one in the middle is most likely a sebaceous squamous cell carcinoma. So if a patient would present to your office looking like this, it's a red flag that you need to send them immediately to ophthalmology. You wouldn't even treat this patient. But you can see the internal hordeolum on the left and the external on the right. And so you do see some pus formation there. On the one on the right bottom, you can see the little pinpoint pustule there. And sometimes if that's popped and you just can take a nail or something and move the pus out of it, it'll heal on its own. But make sure your hands are very clean if you're going to do something like that. And I wouldn't do that to a patient. You could do it to yourself, but I probably would let the patient do that to themselves if they choose to do so. So this is basically the same as the Chalazion. You're going to get the history of a location, the duration, when did it start, do you have pain in the eye, any changes in the vision, and then getting a review of systems, any past episodes, any previous treatments, any family history, anything that they can think of that could maybe cause some problems with this. On physical examination, again, priority is your visual acuity, and it's the same for the chalasia, where you're going to inspect, palpate, evert, and then inspect the sclera and conjunctiva. So when you're diagnosing chalazion in both kinds of hordeolia, it's really more clinical. During the first 2 days, they may be clinically indistinguishable, but between internal hordeolia, which are so rare, they are not usually suspected unless inflammation is severe or the fever or chills are present. If the chalazion or the hordeolum lies near the inner canthus of the lower eyelid, it must be differentiated from dacrocystitis, which usually can be excluded by noting the location of maximum induration and tenderness. So chronic chalasia do not respond to treatment. If they don't respond to treatment, they need to be biopsied, as well as a hordeolum. And the hordeolums usually do resolve on their own, but you never know when you're going to come across one that doesn't. The treatment is very much the same as for a chalazion. You want to make sure their hands are clean. You're telling them to watch, touching their eye. And then the hot compresses for about 5 to 10 minutes, 2 to 3 times a day, probably 4 times a day for about 5 to 7 days. So anywhere from 3 to 4 times a day is fine. If you go over, that's not going to make any difference, but that should kind of be what your norm is. An external hordeolum that does not respond to hot compresses can be incised with a blade, and usually put them on antibiotics. First line, so dicloxacillin or erythromycin 250 4 times a day are indicated if there's cellulitis with that. Usually we refer to the ophthalmologist if you don't see any change in their symptoms after 3 days, and you want to make sure to reassess them. With a differential diagnosis, you are thinking about basal cell carcinoma or sebaceous cell gland carcinoma, as well as squamous cell of the eyelid. And I showed you a couple pictures that you would want to, talk to the patient and maybe send to ophthalmology right away if you do see that. And then your other differential would definitely be your chalazion.